Greetings, everyone, and welcome to this webinar on integrating and scaling mobile community health data systems with a focus on experiences from Ethiopia, India, and Madagascar. My name is Dr. Regeru, and I have the privilege of moderating this session. Before we begin, we have a few points of housekeeping. If you are not speaking, please put yourself on mute. This webinar will be 1 hour long. Each speaker on the panel will have 10 minutes to deliver their presentation, and this will then be followed by questions and responses after we've had all the presentations. Please note that any questions you have may be asked by sending questions directly to me by selecting me as the recipient in the chat section. And I believe we have a demonstration of this now.
Sorry, in order to send a question to Ruggiero, if you select the chat section in the Zoom call, down here you can select the specific speaker that you'd like to send your question to. So if you have it set at everyone will see the question that you send. But instead, if you could select Ruggiero and send your questions directly to him, he will look through those questions and will help him guide the Q&A section of the chat. Okay, so I'm going to flip over to the first presentation that we'll be looking at today. Ruggiero, is there anything else on your end before we hand it over to Kanishk?
Ruggiero, I love that.
Thank you very much for the demonstration of how to ask questions. I just wanted to get started with a brief introduction of myself and then our speakers, and then we can get right into it. So I am based in Nairobi, Kenya, working for a Kenyan NGO named LBCT Health. I work for the USAID SCALE program. SCALE is an acronym. Our program is all about sustaining quality approaches for locally embedded community health services. A key component of this program has been the establishment of quality improvement teams in selected sites in Kenya at both community and sub-county level. And these teams have been introduced to core concepts of quality assurance and quality improvement and the importance of monitoring performance to deliver high-quality community health services. One of the key principles of this approach is that QI is data-driven, which is to say that data must be collected and processed to generate information that is actually used for decision-making. This has meant that a key focus area of our program has been on improving the quality of routine community-level health data. Therefore, today's discussions will certainly be enlightening in this respect. I would now like to take the opportunity to introduce our 3 panelists for this session. Our first speaker will be Kanishka Katara. Kanishka is the Director of Government and Partnerships for Dimagi in the India offices. He comes with an experience of 13+ years in the government transformation business and has extensive experience of working with government partners across 12+ countries. And he is currently leading the world's largest ever mobile deployment for the frontline workers in India and helping in driving the National Nutrition Mission for Government of India. Our second speaker will be Ismaila Dieng. Ismaila is a technical project manager for Dimagi West Africa, based in the Dakar office in Senegal. His role mainly consists in implementing mHealth projects for Dimagi's partner in the Western and Central Africa. In the past 4 years, he was part of 4 projects which implemented an integration of ComCare at the community level with DHIS2 at the Central Ministry of Health level. Our final speaker will be Leona Rosenblum. Leona is the Deputy Director of JSI's Applied Technology Center. In that role, she works to ensure that JSI is equipped to identify, adapt, and apply appropriate, innovative, and effective technology to improve health in the United States and across the globe. Leona's focus is on the application of mobile technology to solve public health challenges. Without further ado, I would now like to hand over to our first speaker, Kanishka.
Well, thank you so much. Thank you so much for this introduction. And good morning, good evening, good afternoon to everybody on the call. I'm Kanishk. I'm calling in from New Delhi right now, and it's about 7 p.m. in the evening at my end. And it's been a pretty long day for me already within the government offices, trying to manage the system which I'm going to talk about, and trying to handle the anticipated challenges which come on a daily basis at such a large deployment. Without taking too much of time, I'll quickly give a background of where this program is happening, why is this program happening, and before we move on to the user-centric elements of the program. India, as all of us know, is one of the fastest growing economies and one of the fastest developing countries in the world right now. And this journey has been on for the last decade or two. At the same time, there are elements within India which always have needed attention. Some chronic problems which have always been impacting India, the rural populace, the poor populace of the country. And one of them happens to be the nutrition element. India, unfortunately, some of the statistics indicate that India is severely affected by the condition of malnutrition. And I'm talking about the government data points. Almost 1/3 of the children which we have in India are stunted. 1/3 of the children in India are malnourished, which, needless to say, is not what anybody wants. And almost one of every second pregnant women, or a female in the reproductive age group, is actually anemic, which again reflects not only towards the lack of awareness of how important nutrition is, what are the core components of nutrition, but it also reflects towards the failure of the general administrative approach towards handling an issue like nutrition. This led to the government to form a comprehensive program which is known as the Integrated Child Development Services Scheme, which Government of India formulated in 1975. And I'm taking all of you back almost 42 years from now. And this program specifically focused on creating a cadre of frontline workers within the ambit of Ministry of Women and Child Development. In India, for reference, Ministry of Women and Child Development is the ministry who caters to the women welfare, child welfare, and the nutrition aspect. We have a separate Ministry of Health, but that's a discussion for a separate day. But as part of this Ministry of Women and Child Development mandate, they formulated this scheme in 1975. The objective of this scheme was to provide supplementary nutrition, preschool non-formal education, nutrition and health counseling, immunization, health checkup, and referral services to the beneficiaries through their frontline workers, which are known as the Anganwadi workers. One Anganwadi worker is deployed at one Anganwadi center, and typically it caters to a population of 1,000 people in her area. There are about 1.4 million Anganwadi centers across the country. This program has been running since 42 years, as I just stated, but it has been plagued with really, serious issues in terms of inefficiency, in terms of lack of accountability or transparency, because everything has been a paper-based system so far in the last 40 to 43 years. And this obviously led to a lot of lag in terms of data being available on the real time, which obviously led to an issue of lack of transparency or accountability. So, which is where Bill and Melinda Gates Foundation came forward and suggested, and they partnered Dimagi for this program. They suggested to the government that let's try an IT-based approach. Let's try and see if technology can play a role in terms of improving this overall program. So this program started almost 2 to 3 years back, where a mobile-based application was developed by Dimagi, which was in turn engaged by Bill and Melinda Gates Foundation along with a partnership with Women and Child Development Ministry in India. The objective was to automate the workflow of these Anganwadi workers, the frontline health workers, give them a tool which can collate data, which can prompt them for service delivery, be a helper in terms of their workflows, in terms of their daily task lists, etc., and enable them to reach out to their beneficiaries at the right time and at the right point in service delivery mechanism. This application, before I come to the application bit, some of the other key stakeholders apart from Government of India and Bill and Melinda Gates Foundation include World Bank, who also funded another component of the program to Government of India, and CARE International is the training partner for this larger program which we have. Initially, the objective was to develop this application, deploy it to a target of about 100,000 Anganwadi workers in 7 states of India, in high burden districts and high burden states. This was way back in 2015 and 16 when all of this discussion and this initiation was happening of the program. Moving forward, we developed the application. Government decided to support with the procurement of smartphones for the Anganwadi workers and the infrastructure support as well. And we were engaged in the capacity of a technology partner, as well as we were given the job of managing the program at a national level. This application got developed. We actually worked with the Anganwadi workers, the frontline workers. At their center, we spent about 8 to 9 months working with them, day in, day out, shadowing them, staying with them, understanding how they work, what challenges they face, what type of registers they have to fill, paper physical registers, what type of formats they need. Can I request everybody to be on mute? I believe there's some noise. Hello, can everybody hear me?
Hi, Ganesh, we can hear you. Folks, if you can mute yourselves, there's some background noise.
Et n'est pas donc touché en ce moment tout le cadre de résultats. Ça va, à notre avis, n'a pas avoir aucun impact sur les rapports de là, parce qu'on peut faire tout en même temps avec les résultats.
So please put yourselves on mute if you're not presenting.
Pardon, c'est quelqu'un qui peut-être est à Madagascar parce que ce qui a beaucoup de bruit, il y a une conversation qui se passe dans le background. Donc,
Okay, I think that'll do it.
Okay, thank you. So as I was saying, this application was developed by staying and working with the frontline workers. So there is a lot of input which has gone from the frontline workers themselves. In other words, this application has been developed by the workers themselves, except that they were the brains for this, and we were provided the hand and the legs to develop this application. This application got deployed across 50,000 frontline workers last year in March 2017, when government procured the first lot of 50,000 mobile phones, smartphones, for which we had defined the mobile specifications, and government did a mass tendering, an open tender to get this. Within 6 months, from March 17 to November 17, the system was deployed across 5 states of India, actually 6 states of India, 6 federal provinces of India. And the data coming in from this system, which is available on a central dashboard, which can be viewed by everybody who has official access to the system, prompted the Prime Minister's office in Government of India to relook at the pending nutrition mission program of India, which was originally proposed in 2002. It's been 16 years since the program was kept on hold, and the Prime Minister personally took interest in this. In November end, this application and the data coming from the application was presented, which formed the basis of Prime Minister approving the National Nutrition Mission, which is a 3-year program with the objective of reducing malnutrition related aspects in India, and finally ultimately making India malnutrition free by 2022. Government has actually allocated more than 100 million USD already committed to support this program, out of which 1/3 is only towards IT support, the information technology support. System has been rolling out for the last year and a half so far. We started with all practically 0 frontline workers. Today, as I speak, we are at 112,000 frontline workers who are live on the system. We have been tracking the usage of the system. We have been tracking the usage of the data coming from the system on a regular basis, and government has been hand in hand with us on that. what we have seen so far is that this program has been one of the best ever successes which we have done as Dimagi. And the current slide shows you the growth of our programs, where system adoption, as far as system adoption is concerned. You can.
Okay, so let's
all right. So
talk about how you're
yeah. So I.
From 2012 till 2017, what's the growth of the programs which Dimagi has done? And in 2017, you suddenly see a massive jump out, which largely has been led by this ICDS cash program, which is the backbone of the National Nutrition Mission of Government of India. We have been tracking the usage of the application very, very actively, because that forms a key, that gives a very key insight as to how well adopted the system is, how the data is being used on a daily basis. And since the system was launched in March 2017, we have been using the data coming in from the technology platform. It shows 82% or more of daily usage of the application by the Anganwadis, by the frontline workers. We are at 112,000 workers. As part of this National Nutrition Mission, the plan is to scale it up to 1.4 million Anganwadi workers, or the frontline workers, in the next 2 years. That's a very ambitious plan, because we are almost at 1/10 of that number as of now. But the government is very aggressive and very, very ambitious on this. The data coming in from this system, which is collected on the Angan frontline worker mobile application, is getting displayed on the national dashboard, and it is displayed in different reports around underweight percentage, stunting percentage, behavior change indicators are there. And this data is being consumed by the government to focus on specific intervention areas, to identify what's happening in different parts of the country. Data which used to take about 6 to 8 months earlier to come in to the central government to take any action is coming in within 20 to 48 hours. And using this dashboard, every single individual beneficiary can be tracked up to the growth monitoring status and what's happening at the ground level. I'll not spend a lot of time on this, because I know I'm almost out of time. What I wanted to convey as well on this was that this has been one of the most, one of the highlights of the current government in India. The system has attracted a lot of attention, and as we progress, there are a lot of requests coming in from other ministries, other government agencies, to be able to share data, to be able to integrate with their own systems. Let's say Ministry of Human Resource Development, Ministry of Education, who want to leverage the data getting collected here, and so that they can then track continuously the individual growth trajectory along nutrition, health, and education system. So it's a long way forward, but so far the data coming in is being used very, very actively across, from the central level to the state level to the district level, right down to the Anganwadi level, to track, monitor beneficiaries, their growth chart, their nutrition status, and ensuring that they get the right support from the government system as far as their nutrition needs are concerned. I'll be happy to take questions on this. I have kept it very short and brief, but feel free to ask me questions, once we reach that stage. With this, I'll close my session, and I'll hand over the session back so that we can move on with the overall presentation.
Thank you very much, Kanishka. Our next speaker will be Ishmaila. I encourage you to continue sending in your questions. We're going to have a question and response session once all speakers have presented. Thank you.
Thank you. Hello, everybody. My name is Ismaila Diène, and I'm based in the Dakar office, and I'm working for Dimagi. And like it was said before, I will present you the Mikolo project based in Madagascar. And the objective of the presentation will be to describe you the project globally and to focus a little bit on the integration of mobile tool application at the community level with the essential reporting system DHIS2 that was used in Madagascar for this project. Next slide. So the project, like I said, is based in Madagascar, and we focus on piloting first an application on 8 communes and scale it later by the end of the project to more than 80 communes in the central and western zones of Madagascar. So like you can see in this first slide, the project was funded by the USAID and MSH Management Science for Health implemented in Madagascar with the Ministry of Health of Madagascar. DMAGI, our role in this project was really to develop the mobile system at the community level and as well to integrate it, like I said before, to the central system at the Ministry of Health. So one of the objectives of this application was to focus really on the continuum of health from the woman at the age of reproduction, so with family planning to following up pregnancies and following up childhood illnesses from 0 to 5 years old. So that was really the continuum of health. So from the woman with family planning to the child up to 5 years old. Next slide. The reasons, some of the reasons why this project was defined and then was implemented in Madagascar was first improve the community level primary healthcare by introducing mobile technology and digitalizing some of the national protocols in Madagascar. So everything regarding pregnancy follow-up, everything regarding childhood illnesses with the different protocols like IMCI at the community level was implemented in this application to really standardize and facilitate the work for the community health workers with their beneficiaries. Another reason was really to increase the adoption of healthy behaviors and practices, notably for family planning or for nutrition, with a lot of counseling that was integrated in the application and with the usage of images, videos, and audios with local languages in Madagascar. Sustainability, developing systems, and really as well increasing the capacity of the partners. The partners being in this case not just the community health workers at that level, but as well the nurses at the health post and health center level, and as well the government team that was trained to maintain and really support the system throughout the time. One last objective was obviously improving reporting. When we're talking about integration to DHIS2 or to any central level system, reporting is a big part of it. So improving the quality of data and the reporting rates was really important for this project. Next slide. So this slide really overall present the overall workflow of the system. And so down on the left side, you can see the beneficiaries where the community health workers provide directly the health services with the application and obviously collect data as at the same time they're providing these health services. So in the workflow, you can see that there are various type of interaction between the community health workers and the health centers in terms of supervision, but as well in terms of transmitting data like referrals or other type of data that goes from the community level to the health center level. So all those interaction when they happen, we developed 3 applications: one from the health center, one from the community level, and one from the supervisor that we call the support technician here, really to integrate all the communication between these 3 levels and to centralize all those in our ComCare HQ platform. The last interesting point here is that the integration with the DHIS2 system at the Ministry of Health level, and how we how we developed that integration and the takeaways we took from that integration. We'll discuss that later in the presentation. Next slide.
5 minutes remaining, Ismaila.
Yeah. So in terms of timeline, we started in December 2016 with the design and the development of the application, and piloted it early in March 2017, over 50 users. So that helped us to gather all the feedbacks, and obviously implemented a second version and scale it to 550 users by January 2018 this year. And hand it over to the Ministry of Health in April. So right now, at the time that we talk, the system is fully owned by the Ministry of Health, and the team of the Ministry of Health in Madagascar is managing the system. Next slide. So the interesting part here, like I said, was the linking between ComCare and DHIS2. And one of the principles we adopted here was to aggregate the data that we receive from the community health worker in ComCare and send it on a monthly basis to the DHIS2 system for the Ministry of Health to really use and analyze those data within DHIS2. So this is just a simple, let's say, visualization of that workflow of the data coming at the individual level from the community health worker in ComCare, the data being aggregated in ComCare on a monthly basis and sent to DHIS2 for the Ministry of Health to analyze and use. Next slide. So some of the main results I'll show here quickly, and maybe we can move to the slide to talk about the takeaways for the integration. So actually, as we talk now, 357 community health workers are currently using the application, with 50 nurses and supervisors as well using it. More than 5,000 beneficiaries are really being covered by those, let's say, 400 users on a monthly basis, and we have more than 16,000 forms that are submitted by the community health workers every month. For the integration, we're sending on a monthly basis more than 300 indicators that are collected from the application to DHIS2. And last point, we have an 80% reporting rate every month, and those 80% are really 5 days after the end of the reporting month. We have more than 80% of the community health workers that submit their reporting. Next slide. So now some of the learnings and takeaways, and I will specifically focus on the integration part. I think integrating two systems, people kind of believe it's a technical work, and you just need engineers or technical people to do the work. But one of the main takeaways is that you definitely need a project manager to organize all the work, because you have so many moving pieces and so many details that if you don't lay out the plan and really make sure you have someone to chase the different parties, and especially if you're working with ministries of health and some with different departments with different needs, you need a project manager to really organize and coordinate the work. Clear ownership is as well key when you're doing integration between two systems. Because if you don't define the roles and responsibilities of everybody, it's really difficult to do it. Next one. Data mapping takes time. So most of the time when you're doing integration, most of it will go into organization, but the rest of the time will be how do you map the data between one system and the others. The data being your indicators, but as well everything regarding users or locations and things like that. And last point, mature systems. So you don't want to integrate two systems that are consistent, that are not yet mature, and that are not yet at a kind of a stable phase. So before starting any type of integration, you just need to make sure that the system A and the system B are at a mature and stable phase. So you make sure that the work you're doing is not going to be obsolete a few months later. Yeah, so that was it. So if you have any question, don't hesitate to post them, and I will answer to them later. Thank you.
Thank you very much, Ismaila. On to our final speaker, Leona. Please keep on sending in your questions.
Leona, I think you may be muted.
Hi, can you hear me?
Yes, we can.
Great. So thank you for the introduction. My name is Leona Rosenblum, and I'm going to be talking a little bit about JSI's experience supporting the Ministry of Health in Ethiopia to achieve multiple visions for improving health extension workers' quality of service delivery and also of information systems at the community level. So the application that I'm talking about originally began specifically supporting the RMNCH Directorate of the Federal Ministry of Health of Ethiopia. But the story that I think is interesting for the discussion today is how you take multiple visions of what a fully integrated system would look like, what scale would look like, what a comprehensive application would look like, and merge all into one behind the vision of the ministry. And so we can go on to the next slide. So talking a little bit about Ethiopia's Health Extension Worker Program, which I'm not sure if everyone is familiar with, but it's a comprehensive primary health care program down to the community level. So with the health extension workers at health posts, and then a health development army working directly within the community with households. And health extension workers in Ethiopia provide a package of 16 services across all health areas at the community level. And one of the key issues that JSI was asked to tackle with Dimagi originally was around coverage, timeliness, quality, and referral linkages, specifically for maternal and child health services. And the issues there are touch on sort of the comprehensiveness of the program and the wide scale of 40,000 health extension workers. It's very difficult, as someone I believe was mentioning earlier, to ensure the reach and the quality of all of those services and support all of those health extension workers with the supervision and tools that they need. So this application was really designed to support the health extension workers and improve those key areas that have been identified as challenges for achieving RMNCH health outcomes that were within the ministry's goals. So you can go on to the next slide. As I think you start to hear a theme, but which sounded pretty familiar in what Ismaila was just talking about, the application was designed to support health extension workers, but includes actually 3 interlinked applications, one for supervisors at the health center level, and one for registering some client information at the health center level to ensure continuity of care as clients move between levels. So the application that was designed was phased into 3 releases because the content covered was so broad. So on the left, you can see starting with the continuum of care for pregnancy, so ANC, delivery, notifications, and postnatal care, and then moving into nutrition, family planning, immunization, and then integrated management of childhood diseases. And so each of those program areas follows the same type of workflow: registration, health extension worker, client interaction, reminders and notifications for any sort of appointments and defaulter tracking, and then at any point referral up and down to the health center, as clients can be managed at both levels. And then at the same time, you're looking at reporting, so job aids for paper reports as well as aggregate indicators being automatically generated based on case data, and then supervision for improved performance, both in terms of tracking performance of using the application as well as the health services delivered. So just for a little bit more information on how the application was designed specifically for the first release, you can go on to the next slide. You can see that registration for clients takes place at the health post, and then they move up through the system to receive ANC antenatal care first visit at the health center. And then in an ideal flow, they receive the next 3 visits at the health post, deliver at the health center, and then postnatal care is provided by the health extension worker in the community. And the application is designed to support all of those entry points and the movements of the client through the system with supervision happening throughout. So you can go on to the next slide. So what I think is most interesting to discuss here is how this application fits into the larger vision that the Ethiopian Federal Ministry of Health has for the e-health architecture and information systems in the health system in Ethiopia. So I know that there's a lot of small boxes on this slide, but if you can look, there's sort of a few main components of what the architecture is supposed to look like as we move towards this future state vision. And you've got shared services and then key data sources, population-based data sources, and analytics and business intelligence pieces. But then with point of service HIS, you're looking at key entry points of data at point of care, and one of those is the ECHIS, which is the Electronic Community Health Information System. So a lot of the work that we actually wound up doing around integration of the work that has been done on this RMNCH application with the larger e-health architecture was about sort of defining and rationalizing what is a service delivery application, what is an electronic community health information system, how do they overlap, how do they support each other, how does a tool that's already rather comprehensive for a wide range of RMNCH program areas fit into something that needs to cover the full range of primary healthcare services for the 16 packages that the health extension program provides. And so over time, that conversation needs to require stakeholders from across the ministry, from across different development partners. It's beyond the scope of, say, of health IT. The health IT directorate has been working closely with the RMNCH teams and HIV, infectious disease, different parts of the ministry need to be engaging with each other and with different actors. And so that's been a key focus for us, is really getting alignment on that vision so that we can all work together to achieve it. Because if you look at the scope of what's included in the application, which is digitizing a family folder that covers all households in each catchment area for each health extension worker, and then includes just so far the reproductive, maternal, and child health services that are provided, that's already an enormous scope. And as we add in the different program areas beyond RMNCH, we believe that we're already kind of approaching the largest scope of a mobile health application for frontline workers. You guys can all suggest if I'm wrong on that, but I believe that it's just the amount of content that's included in the application and the services that are supported becomes really groundbreaking. And the scale of usage that we're aiming towards, the electronic community health information system vision for the ministry is to support all health extension workers, which is about 40,000, covering
1
the
minute
full
left,
population
Leona.
of Ethiopia. So if you want to go on to the next slide. I think the key successes and lessons learned were that the real key to all of this is that the FMOH has strong leadership and vision, and they've been leading the charge on what the final outcome it needs to look like in the ECHIS. The most difficult part, but also the key to success, is having clear scope and vision of who the end user is and how you prioritize that so that you can facilitate a user-centered design process. And then the users need to find value in the application. And what we've found so far is that the key value has been in that quicker sharing of information between levels and better ability to manage clients over time as they can follow where services are being received and know what's needed next. But I'll pause there, and as I think I'm out of time, so thank you.
Thank you very much for Leona. Thank you to all our speakers. We now have about 20 minutes of this webinar left. So we've now entered our portion for questions. Thank you for sending them all in. Before I proceed with the questions, just a note that this webinar is being recorded, and the recorded webinar and all the PowerPoint presentations that have been delivered by the speakers will be both saved on the CHW Central website. So these will be available to us after the webinar. Going on to the questions, I think it's best if I've done my best to compile the questions that have been asked, and where there's overlap, combine them. So I'll just read out the questions addressed to individual speakers, as well as questions that I think all the speakers can be equipped to answer. So allow me to go through the questions first, and then we can get the responses. So for Kanishka, we have questions from Miriam, which are, with so many users, how do you handle tech support and troubleshooting? And in terms of the data dashboard that you referred to, is this accessible from desktops only, or is it mobile and integral to the app such that frontline workers are able to see it? And also, is it national or the government state hosting the information, or is this Dimagi? And a question for myself is that you mentioned that the front helpline workers were taking part in design of the mobile technology, and I was hoping you could tell us more about this. For Ismaila, the questions we have for you are from Mohammed, is that he has an immunization registry in his country that is mobile-based, and they're now moving to communities and plan to have an application as well. However, there are many existing platforms making it challenging to choose between this. And is there a concerted tool that is mobile-based that they may be able to use? A question from Giselle is whether you had Dimagi staff on the ground. I believe you mentioned a project manager, but wonder if you have any more staff on the ground. Question from Miriam and Giselle are whether CHWs have access to aggregated data and whether they're able to use it for decision-making. A question from Lynette is whether there's any validation of the information collected by CHWs before it's uploaded into the DHIS. And lastly, whether the CHVs receive any incentives to do their work. Finally, to Leona, questions we have for you is whether you use the DHIS2 as the national warehouse for this data as you continue to support integration of the different systems. And also, how long did it take to train health extension workers to use the technology and collect data with fidelity? And finally, I've come up with two general questions that have been asked that I feel can apply to any of the speakers. So the first of those questions would be, have you had any feedback from the community health workers or the frontline health workers in the sites in which you're working as to how useful these systems have been to them? And secondly, what systems or mechanisms are in place for the data that has been collected by community health workers who've used these systems to feed back to the community themselves? So the household members, religious leaders, chiefs, etc., to actually get them engaged with community health services. We look forward to your responses.
Perhaps we could begin with Kanishk, since Kanishk presented first.
Yeah, hi. Thanks, Lily. Am I audible to everyone?
Yes, absolutely.
Okay, cool. I'll start with the question of engaging, the contribution of the community health workers as far as the system design is concerned. So when I said that, my team, the Dimagi team, stayed with the workers, what it literally meant was actually what I said, that the Dimagi team, the developers from Dimagi, because we were engaged in an enterprise capacity to develop this entire system. So we actually stayed with these frontline workers for a good period of 8 to 9 months. And we actually shadowed them. We used to develop application or a specific module of the application or a specific workflow on a daily basis. But during the day, we used to spend time with them, see how they are maintaining their registers, how they are visiting their beneficiaries, how they are counseling them, what data points they are capturing. And in the evening, once we were back after the visit to our respective guest houses in the local area, we used to sit and develop those workflows on our laptops. Overnight, we used to deploy them on a mobile phone, which is one of the USPs and the key functionalities which the Comcare platform allows for. The very next day, we used to go back to the frontline workers, show them the mobile application, show them the module which was developed, take their feedback if this is exactly what they will want to see in a aspirational, in a desirable mobile application if they had to use it in place of the paper. So this process continued, this iteration continued for a good period of 6 to 7 months. Finally, at the end of this period, we had the base version of the application ready, completely covering their entire workflow. There are 11 registers as part of the ICDS program, out of which 10 registers have been automated in this application. The entire weight of these 11 registers is about 8.2 kilograms, which effectively government has actually replaced with a 170-gram mobile phone. I'm just jumping the gun because there was a generic question as to how useful the system has been to the community health workers, and how well they have adopted this. I mentioned that the average daily usage of the system across this large scale has been almost 82% or more. And one of the things is that they have given the feedback that, earlier we used to carry so much of registers and paperwork, such cumbersome paperwork. They had to manually draw the growth chart using the x-axis, the y-axis, plotting height, weight, etc. Now the application is doing it for them. They can carry that small piece of device, 170 odd grams, and they can manage everything which they were supposed to do manually. This is on the community health side, and also on how the users were engaged for the design perspective. Even after the rollout, we ensured that we go out on a monthly field visit to different pockets of the country, to different parts where the system is available. And we still continue to engage with these workers to see what their feedback is. What are the challenges they are facing in terms of system usage or the data which is coming up as part of the system. We bring that feedback back to the central location in New Delhi. We discuss with the ministry officials as to this is the feedback and this is how we can improve the system. And with their approval, they generally agree because this is valuable insight coming in from the field. We further improve the system. This process is a continuous iterative process. This has been on. And I expect this to be on for more foreseeable future because the system continues to scale to uncharted territory across the country. I'll address the question on hosting now.
Just before you respond, we'll give you 2 more minutes and then we can move on to the other speakers to answer their questions.
Of course, sure. The system is hosted on a government data center, which has been, procured and provisioned by the ministry. There is no hosting happening on Dimagi server or any private server. It's a completely secured government data center. And this was a precondition which we explained to them at the time of system design. So government agreed to, be hand in hand as a partner on this, and they have arranged for that entire bit. The question on linkage with any other state or national health information system, the matter of fact is that for ICDS program, for Ministry of Women and Child Development, there is no system available. There was no system available at the time this system came into existence. We have a national dashboard. The system has data of almost 17.8 million households as we speak right now, registered into the system. There are almost 10 million children registered in the system as of now, which are being tracked live. The system engages with the beneficiaries by sending automated alerts to the people, informing the beneficiary mothers, the mothers of the kids, telling them that the weight of your child or the growth of your child has not increased in the last month, so please contact your nearest frontline worker for necessary advice. Or your child is in a severely underweight situation, so immediately please contact the nearest facility for the next steps on that. As part of the help desk, or how the system
Kanishka, I think I'll have to cut you off there just to allow the two other speakers enough time. I think we'll be able to post written responses to the questions for what we don't manage to cover in the next 10 minutes.
Okay, of course. Thank you. Thank you so much.
Thank you very much, Kanishka. Over to you, Ismaila.
Hello. So maybe to answer quickly, maybe to Mohammed question first, is there a concerted tool that is mobile based and we may be able to use? I'll preach for my church maybe. ComCare is, I think, one of the tools that is out there that DMAGI has developed, and that is a perfect community health worker tool and really flexible. So that's one tool you can explore, obviously, and see if it works for your need. Giselle question maybe about were there DMAGI staff on the ground in Madagascar? Yes, not 100% of the time, but we had several trips there during the implementation phase, during the deployment phase, etc., just during the scoping phases, to make sure that we have like a heavy presence on the ground. But our partner MSH was on the ground all the time and was doing a lot of the work on the ground in terms of discussing with the Minister of Health, but as well in terms of implementing and deploying the system. You were asked, Giselle was also asking if the data was aggregated by CHW or by health catchments. It was, okay, so for ComCare, the data in ComCare was aggregated by health catchment to be sent to DHIS2. And the main reason was because the DHIS2 system didn't have the CHW level in their system. The lowest level was the health catchment, so we had to stick with that. But in ComCare today, we can go down to the CHW, obviously. Miriam was asking if the data aggregation was happening at the ComCare HQ level. The answer is yes. And if the CHW or the supervisor were able to visualize the aggregated data, and the answer is yes as well. We build what we call mobile reports, which basically allows the CHW to see the past month aggregated data they have submitted, and as well to compare some of their indicators to the CHW around them, and that was implemented to kind of motivate the CHW and say, okay, look at the CHW next to you. They've done so many such and such number of visits, etc., etc. And the supervisors were also able to see those aggregated data. Question from Lokov: any insight in a specific level where data is validated? In the model that we define, all the data was sent to DHIS2 monthly, and the data validation happens in the DHIS2 before validating the whole data in DHIS2. So the idea was that all the data was validated in DHIS2 before integrating the data into reports and things like that. I think that was it. Maybe is there a last question?
I think there's a question about whether CHPs have any incentives for their work.
Yeah, no. So they are all volunteers. All the CHVs were volunteers, so no incentives for their work. And that's the model that is pretty much the same in all Central, Western Africa, and Madagascar as well, where the CHVs are really working for their communities. So that's the main motivation. Another motivation here is that obviously we bring mobile technology and devices that were not pretty common in some areas. So the CHV's motivation was to be seen as kind of a model in the community providing these health services, and as well having these new tools.
Thank you very much, Ismaila. Over to you, Leona, for the last few minutes.
Sure. So I think the first question for me was about CHIS2. And the vision for the eCHIS is that eventually the data collected at the community level will be used to create the aggregate indicators that are needed for DHIS2 and integrated directly into the system. Since the eCHIS is still under development and currently it's being used, the RMNCH application is being used by 250 health extension workers across 4 districts and 4 regions. It's not appropriate to have data integration directly yet, as people still are using the paper system. But that is the vision eventually. I think in terms of the actual data warehousing for all of Ethiopia's health information systems, I don't believe that will be actually in DHIS2. But in terms of getting the indicators from the community level to be directly reported with still validation at the health center level, that is the vision. In terms of training, I think that's one of the things that we're still iterating on, is exactly how long does it take to get health extension workers fully up to speed, and what is the best training model. And if we had more time, I'd love to hear sort of thoughts from the colleagues in India and Madagascar as well. What we've found is we've been doing a 5-day training, and what we find is that perhaps it's possible to do that training for fewer days, but with more hands-on support after. So doing a training for longer, which is sometimes what the users have requested, doesn't seem to necessarily equate to better usage and comfort with the application. It's more having immediate post-training support to actually implement the first few uses, and then continued supervision specifically on the use of the application. So we know that supervision is sometimes more limited than we'd like it to be in general on health service delivery as well. And so making sure that people are getting both troubleshooting technical support, but also just continued application supervision support is key. And that's, a part of the reason why it's so important to be working through the larger health system, because that's where the supervisors who are closest are available. I know we're running short on time, so just to talk about the one general question, the first one about feedback, I think I started to talk about this a little bit at the very end of my presentation, but what we've been hearing from the health extension workers is that they really appreciate being able to see information from the health center. That I think Ethiopia is somewhat unique in that so many services can be delivered in both locations, and it makes it rather difficult for them to track whether their clients are up to speed. And also in terms of being able to see what appointments they have and manage their appointments. I think, as the colleague from Madagascar mentioned, I think that the question of using it during visits is sort of the key question for our team, and we've just been doing a usability study with all of our users that hopefully we'll have some more information to share in the next month or so about those results, because I think that when you look at quality of care indicators, the key is whether it's being used at not just that point of care, but during the visit. And that's where I think there's still some hesitation about the amount of time it takes and, whether there's still a need for paper reporting, et cetera. But I'll wrap up there since we have 1 minute left.
Thank you very much. That is a very timely finish. I would now like to take this opportunity to thank Dimagi for organizing this webinar. I'd like to thank all the speakers for their presentations and the response to their questions. And I'd like to thank all the participants in this webinar for your attention and your questions. As I said, the webinar and the presentation slides will be shared on the website, and we'll also comb through the questions asked, and anything left pending we'll make sure to post to the website also. Thank you very much. Any additional questions can be sent to lalson@dimagi.com.
Thank you all.